And a very great privilege to have as our speaker tonight Dr. Anthony Fauci, the director of the National Institute of Allergy and Infectious Diseases at NIH, and I think easily one of the most prominent scientists in this country. He's a man who literally needs no introduction. Many of you have probably already seen him on television or elsewhere, where he's emerged as one of the most effective spokespeople and educators in the area of infectious diseases. Before I introduce Dr. Fauci, I just want to mention that this is sponsored by the Hertog Global Strategy Initiative, which is a research program in the Department of History that employs historical analysis to confront present and future problems in world politics and really ask the question, how can we learn from history to have a better understanding of how to deal with future problems? What can history teach us about the future? Next year's subject will be another one of the four horsemen of the apocalypse, religious violence and apocalyptic movements. So literally, one of the four horse people of the apocalypse. We thank the Hertog Foundation and Roger Hertog for their support of the program. This program is also co-sponsored by the Center for the History and Ethics of Public Health at the Mailman School of Public Health at Columbia University, and we're delighted to see the Mailman School is also very well represented tonight as well. The Global Strategy Seminar of Columbia University is also a co-sponsor. And finally, we are delighted to be able to thank the Public Affairs Department, the Communications Department at the Mailman School for the refreshments, which I hope you will all have a chance or have had a chance to enjoy. I also hope, and we all hope, that you will come back next year. There is another speaker next week as well, but come back next year for the program on next year's subject on religious violence. So it really is my great pleasure and privilege to introduce Dr. Fauci, who's really been a great visionary in the field of infectious diseases. Indeed, the idea of emerging infections, many of you may know that the very first conference on the subject was held by NIAID under NIAID's auspices in 1989 and led to what has now become almost an industry on emerging infections and emerging viruses, which was the original subject of that conference. Dr. Fauci became director of the National Institute of Allergy and Infectious Diseases just as the HIV/AIDS epidemic was beginning, and so has been the director through many interesting and obviously very challenging times. Recently, people have spoken about the HIV/AIDS epidemic at 30. It was recognized just about 30 years ago now, and Dr. Fauci became director of the Institute in 1984 and has really been very effective in educating and obviously developing research programs on HIV and many other infectious diseases. So I won't take much time with a formal introduction, since I think he'll have a lot of interesting things to tell us, only to mention that he is also a graduate of the Cornell, now Weill Cornell Medical School, and a specialist in infectious diseases, and still works actively in the field of immunology and immunologic research. Where you find the time, I have absolutely no idea, being so busy, obviously, with this very important position as director. So it is my pleasure to present Dr. Tony Fauci, who will talk about 30 years of HIV/AIDS, a personal journey.
Thank you very much, Steve. It's really a pleasure to be here with you this afternoon to talk about this extraordinary subject. I think it's very appropriate for me to address this audience with the interest that I know permeates so many people in the audience from a couple of standpoints. As many of you know, HIV was first recognized, not the virus, but the disease itself as a new syndrome, in the summer of 1981. So that's exactly 30 years ago. And number two, I want to talk to you about, and I use the terminology, a personal journey, because it really has been an extraordinary personal journey for me, being one of the few people, I believe, who was there and began working on this literally from the very first weeks of the recognition that we were dealing with something unusual. And I'll tell you the story about that as part of this personal journey. And as someone who is still working on this. So I have an unusual experience, for better or for worse, of having been through essentially every day of those 30 years. And as I mentioned to the students just a little while ago in a very enjoyable meeting I had with some of the students, that what's going to come in and out of this discussion is going to be the issue that what happens to you in your professional career is very often unrelated to anything that you do. It's just almost by accident. You have to be well prepared. I believe you have to be reasonably smart. You can't be a dummy and do good things unless you're really lucky. But it's opportunities that come your way, and I'm going to talk a little bit about them and weave them in to this story of my personal journey through this historic pandemic. So it didn't start off in the summer of 1981. I had an interest, obviously, in medicine, and as Steve mentioned, I went to Cornell University Medical College and did my internship and residency there. And here's a picture of me as an intern, actually, at the New York Hospital in medicine. Spent a few years there. And then I had an interest in infectious diseases and the interface between infectious disease and immunology. So you may ask, okay, that's nice, who cares? But the interface of infectious diseases and immunology was something that I could not have predicted would have poised me to be in a very interesting position to study a syndrome that I didn't imagine would occur at that time as I was doing my internship and residency. So I went down to the National Institute of Allergy and Infectious Diseases at the National Institutes of Health. So why did I do that? Well, when I graduated medical school and did my internship and the residency, and this is one of maybe 6 or 7 things that happened to me that were completely beyond my control. We were in the middle of a war, the Vietnam War, and we all got drafted. So I got drafted like everybody else did, but when we were a physician, we were asked to prioritize whether you wanted to go into the public health service, the Army, the Navy, or the Air Force. I was interested in infectious diseases, so I said, put the public health service. I'd go to either the CDC or the NIH. If I didn't get that, I put the Navy second, the Army third, and the Air Force fourth. No offense to people who served in the lower group there, but that's what I did. As it turned out, I was accepted in the public health service, and that's why I went to Bethesda as opposed to doing a residency and a fellowship in infectious disease at Cornell. Completely beyond my control, point number one. So I went to the NIH, and I had some interesting experiences with some extraordinary people. One of the most important of which was a fellow who was my mentor, a fellow named Sheldon Wolf, who nobody in this room I would expect to know. But he put me on projects that I almost was not deserving to be on because they were very exciting projects that had nothing to do with infectious diseases. They had to do with immunologically mediated diseases like Wegener's granulomatosis and the vasculitides, which was the early part of my career that I was fortunate enough to make some significant contributions to. Again, luck just threw it in my way. I did a 3-year fellowship at the National Institutes of Health, and I came back to the New York Hospital to be chief resident in medicine. And here's a picture of me. Notice the hair's different. You can always tell what year it is. Look at somebody's hair and their glasses, wire-rimmed glasses, long hair, 1970s. So I did that for a year and then came back to the NIH and got involved for about 10 years in a group of projects that were highly successful. And I want to take a moment particularly for the younger people in the audience, to tell you about how you make decisions and you're not really sure why you make decisions. I started studying these inflammatory diseases, and by chance, 2 floors up from my hospital at the NIH in Bethesda was a person named Vince DeVita and Paul Carbone, who were developing independently the cure for Hodgkin's disease and acute lymphoblastic leukemia. They were good friends of mine, and they were using combination chemotherapy. One of the drugs was cyclophosphamide. So I was studying a non-malignant inflammatory disease that was 100% lethal. So we got the idea, if we use cyclophosphamide in a high enough dose to suppress the immune system, but not so high as to kill the patient and wipe out their bone marrow, maybe we could shut off this disease, which was Wegener's granulomatosis or vasculitis. As it turns out, we developed the cure for the disease. So at 27 years old, I was in the entirely unlikely situation of having made a major contribution in medicine. So I thought that was my career, that's where I'm going. But it wasn't infectious diseases. And I had been fascinated by infectious diseases and global health. So despite this great accomplishment at a young age, I was, as they say, restless about what I wanted to do. Then one day, in June of 1981, this landed on my desk at the NIH in Bethesda. It was a report of 5 otherwise healthy gay men from Los Angeles who were presenting with a bizarre pneumonia called pneumocystis pneumonia. Now, most people didn't have any idea what pneumocystis pneumonia was. I happened to, because I had gotten my boards in infectious diseases, and I was the infectious disease consult for the patients on the Cancer Institute who were getting chemotherapy for cancer. And every once in a while, because their immune system was suppressed, they wound up getting pneumocystis. So I was very familiar, and I was saying to myself, why 5 gay men, otherwise healthy, getting pneumocystis pneumonia? I thought it was a curiosity. I threw it on another part of my desk. 1 month later, the 4th of July of 1981, another report from the CDC. Now 26, interestingly, all gay men, not only from LA, but from New York City and from San Francisco, who presented not only with pneumocystis pneumonia, but with also an unusual cancer called Kaposi sarcoma. Now, I know many people in the room know this, but this never occurs in someone with a healthy immune system. So I said to myself, and then I announced it, much to the chagrin and the advice of my mentors and colleagues, I decided that I was going to stop studying inflammatory diseases and devote my immediate energies to admitting these gay men with this strange disease called gay-related immunodeficiency at the time. My mentors thought I was nuts. They said, here you are, you're a young man, you're relatively famous as a physician. Why are you giving it up to study this disease that's only affecting very few men who are in a very restricted epidemiological population? Well, that winter published the following spring in the Annals of Internal Medicine in 1982, long before we even knew that HIV was the cause of the virus, I wrote a commentary for the Annals of Internal Medicine called The Syndrome of Kaposi Sarcoma and Opportunistic Infections, an epidemiologically restricted order of immunoregulation. It wasn't even called AIDS yet. And one of my quotes from that paper was, because we do not know the cause of this syndrome, any assumption that the syndrome will remain restricted to a particular segment of our society is truly an assumption without scientific basis. And I was actually criticized by that as being an alarmist. And there were a couple of newspaper comments about this, as this infectious disease person at the NIH was being alarmist by suggesting that this was going to spread well beyond the restricted gay communities in the big cities. Well, then, month by month and year by year, soon after that, remember the article was published in June. In July, Kaposi sarcoma among Haitians, pneumocystis in hemophiliacs, transfusion-associated disease, unexplained OIs in infants. We didn't know that their mothers were infected at the time. Immunodeficiency among female sexual partners of males with acquired immunodeficiency. So it started to unravel in a way that, quite frankly, we all know now, retrospectively, was truly historic in the annals of global health and infectious diseases. So here's a picture of me on rounds in the NIH hospital admitting patients in which it's a very unusual feeling that it's difficult to describe. When you bring in patients, you have no idea what's causing their illness, and they all die. So I've described that as the very dark years of my career. But I had to do something, so I had to do research. So my laboratory before AIDS was an immunological laboratory, and we were studying B cells. So we had a fellow in my lab, a very young man who was coming in for a fellowship named Cliff Lane. And I said, Cliff, why don't we start studying B cells in HIV-infected individuals? And we did. And we found out something that is a major paradox, that despite immunodeficiency, there's an aberrant activation of cells. This was the first paper before HIV was even discovered that indicated that aberrant immune activation was a major pathogenic feature of HIV. And now 30 years later, as some of you may know who are in the field, aberrant immune activation is the driving force that allows for virus replication. So this was a serendipitous finding that I had no idea what it meant. But God bless the New England Journal of Medicine, they allowed me to publish it even though I didn't have an explanation for it. Next came the first description of the antigen defect. Now, I'm not going to say anything else at all for the remainder of the talk about any research that I've done over the last 30 years for HIV, because what I want to tell you is a heck of a lot more interesting, I think, than giving you a list of papers that I published. So let's go through the evolution of this interesting story. I hated administration. I'm a clinician and a bench scientist. But it was clear to me that the response of this country and the research community to HIV was not adequate. So the director of NIAID retired that year, Richard Krause, still a dear friend. And I was asked to become the director of NIAID. And I was, as it turned out, the youngest director that they've ever had at the NIH. I didn't want to do it, but I said to myself, even though I don't particularly like administration, maybe I could put myself in a role that'll have some influence not only in HIV, but in infectious diseases and global health in general. So I made that choice, which retrospectively clearly was the right choice. That put me in a world that I took to, but was not trained for. And this is a picture of me testifying before the Congress of the United States. So I went back to my congressional colleagues and asked them to look in the congressional record. And I find that with HIV and what we've done with SARS and West Nile and H5N1 and H1N1, I have the world's indoor record of testifying before Congress for 210 times in the last 30 some odd years. So it's an interesting phenomenon. I've been beaten up by some of the best congressmen and senators in the country. Now, the other thing that was very important that put me in an arena that I never would have imagined is that because of the nature of the problem, I got to have what I call interacting with presidents. And it was a very interesting experience that I'd like to just share some anecdotes with you because they are clearly true, but they are not the kind of thing that you would expect. The first person that I developed a relationship was with Ronald Reagan. Now, Ronald Reagan, as you know, was vilified, and I think partially justifiably, for his reluctance to be public about HIV, to come out and say, we have a problem, we need to do something about it. And he did that likely because he didn't want to offend his conservative base. But what he did do that people don't know is that he allowed me, and personally discussed it with me and Jim Curran and others at the CDC, to go out and really try and figure out what was going on with this pandemic, which we did. We didn't get a lot of money for it, but we went out to the bathhouses in San Francisco, into the crack houses in Brooklyn, and looked around, trying to figure out just what was going on here. It was readily apparent it was a sexually and blood-borne infectious diseases. You didn't need to be a genius to figure that out. But there wasn't major administration interest in it. However, when George H.W. Bush was vice president and decided to run for the presidency, he realized that HIV would be an important problem. So he wanted to know about it. So for the last few years, I had been doing nothing but HIV. So he called up the secretary of HHS and said, I heard that this guy Fauci down at the NIH who's doing HIV stuff, is there any chance we can go down and visit the NIH? And here's him when he was vice president visiting, and he became extremely interested in it. And that was the first big blip in the budget. To my great honor, I developed a friendship with him when he was vice president, which set a rule for me that I'm going to give you several examples for. When you're in Washington, be nice to everybody, because you never know where they're ultimately going to land. So he, for reasons that I still can't explain, he still communicates with me by his handwritten notes in such a wonderful, warm way. He became fascinated with that, and we became good friends. When he became president, he visited the NIH several times and built up the funding at my and the assistance of others for HIV research, and he did the same thing for the CDC. So here's him visiting with Mrs. Bush. On a separate visit, he wanted to get to understand the whole issue of what it feels like to be HIV infected. So we thought we would introduce him to a bunch of patients. So here he is. You may not see it well. I'll get a close-up. Here he is in our solarium, where we generally have the patients have some recreational time. And all of these individuals here I'm here, are HIV-infected individuals. So I'm sitting here, and he's talking with them. The second example of the rule, when you're in Washington, be nice to everybody. Because sitting here in this corner is somebody that you might recognize. And that was George W. Bush, who was a staffer at the White House with his father before he became the general manager and owner of the Texas Rangers, and then ultimately the governor of Texas. And in my new role of being nice to everybody, I was really nice with him, and we developed a friendship even before he became the president. And the reason I tell you this story, it's going to become extremely relevant in a few minutes when I tell you how things evolved. President Clinton, again, was very, very interested in that, and took an interest a lot in the science, because, you know, what you read about Clinton, he is a wonky kind of guy in the science. In fact, when he invited me to the Oval Office subsequent to this to talk about HIV, I asked his chief of staff, who was Leon Panetta at the time, what, did he want to hear like a broad epidemiological study, or did he want to hear about the science? So of course, Clinton said, I want to hear about the science. So here I am in the Oval Office explaining to him the interaction between the HIV envelope and CD4 and the CCR5 receptor, because the CCR5 receptor had just been discovered and published like the previous year. And from the look in his eye, he was asking his typical question, well, what do you think about that receptor? This is Al Gore, who I know is thinking that I must have discovered this receptor. No, but it was just kidding. Just a joke, I'm sorry. example 3 of when in Washington, be nice to everybody, because this is a picture of Hillary Clinton when she was the First Lady, and we developed a very fond relationship, which was extremely helpful when she became the senator from New York and now the Secretary of State, and we'll get into that when we talk a little bit about the Global Health Initiative. This is George W. Bush, which we'll get back to in a moment, who rekindled his interest in this when he came back as president. And obviously, President Obama, here visiting me and Francis Collins at the NIH, had the opportunity to discuss with him some of the issues. The unfortunate issue with President Obama is that he now is living in an arena of extraordinary constraints on resources. So although everyone would like to have an explosion of resources, it's going to be very, very difficult to do. And I'll get into that in a second. So that's the background of it. So let's take a look at, from that first MMWR, where there were 26 plus 5 patients, to where we are right now. The new numbers have just come out from the CDC and the UNAIDS. 65 million people were infected with HIV. About 30 plus million have died. 34 million living with HIV. 2.6 million new infections a year. 1.8 million deaths. And as I mentioned, cumulatively, 30 million deaths, 1.8 per year. So if you do the math on this, we're used to HIV/AIDS because we've been living with it for 30 years. But historically, it's one of the most impactful pandemics in the history of our civilization. If you compare it with anything, bubonic plague, smallpox, measles, the pandemic of 1918, it ranks on that short list. In the United States, we've become complacent. There are about 600,000 deaths. Interestingly, 1.2 million people are living with HIV. Importantly, 20% of them don't know they're infected. And 50% of all new infections come from a person who doesn't know that he or she is infected, that inadvertently infects somebody else. So this is a group that we haven't gotten to. So in 2009, still, male to male, or men who have sex with men, still is the major risk category. The striking thing that some of you may have read the New York Times yesterday when Don McNeil wrote about the CDC's new numbers, that the incident rate among African Americans is 8 times higher than among whites. And although we're stable at 50,000 new infections each year, there is an increase among black men who have sex with men. So in 2011, in the gay black population in the United States, the incidence is increasing. Get that? It's not stable and it's not going down. It's increasing. So we can, I hope we have a question period later. I'd like to get into why those things that happen, but I'll leave it for a little discussion later. So the NIH research funding has been extraordinary. This is what it was early on, and then this is what happened when I told you we finally were able to have a person-to-person dialogue with George H.W. Bush and with subsequent presidents. So now the NIH has cumulatively spent $45 billion that's on AIDS research alone, and it's about 10% of our budget. The NIH budget is about $31 billion. We spend about $3.1 billion a year on AIDS research. So there is an extraordinary effort. When you put that much resources in, you get results. There have been now, I show this is interesting, I did a search 3 days ago. So if you plug in HIV, you get 228,000 papers that were published. I must confess, I haven't read every one of them. But I've looked at the titles of every one of them. I've read most of them, but not all of them. But what that really yielded was extraordinary advances in science, etiology, diagnosis, natural history, but nowhere has there been as great an impact as in the arena of treatment, which tells you when there's a will to get a therapy for a disease, you can get it. So let's go back to a discussion of the treatment of HIV-infected individuals. We'll go back to my making rounds on my wards in 1981. So this is a picture of me in the fall of 1981 with an HIV-infected individual. I mentioned to you that that was the dark years of my medical career. It's very difficult to describe because remember, the reason I told you that little anecdote about developing the cure for inflammatory diseases, for 10 years of my life, every patient that came in with a lethal disease, we used the Fauci protocol, and they walked out of the hospital and they hugged me and said, "You've saved my life," and it was really a great high to be on. For the next 10 years, it was exactly the opposite, is that people came in and instead of being a healer, we were healing nobody. 6 to 8 months was the median survival back in the 1980s. In 1987, the first glimmer of hope, this is the New England Journal of Medicine paper showing that when you used AZT in HIV-infected individuals versus a placebo, over the period of 24 weeks of the study, 19 people on placebo died, 1 person on AZT died. This was the first and the only placebo-controlled trial of therapy in HIV for obvious reasons. You can't ethically do a trial when you have a treatment. Number one. Number two, it was the fastest approved antiviral or antibiotic in the history of the FDA. Now, everybody was on a high because we now had a drug. It was short-lived because what we kind of realized but didn't admit, when you have a highly replicated RNA virus, it will mutate and it will develop resistance. And that's exactly what happened. But that didn't stop the research community. This is the replication cycle of HIV with fusion entry, reverse transcription, integration, and then budding using the enzyme protease. We've now, over the last 26 years that we've been trying to develop drugs, have drugs for each of these targets. And we have now 31 FDA-approved drugs, which, as many of you know, when used in combination, have completely transformed the lives of HIV-infected individuals. So that in the same building that I showed you where I was at the bedside of the patient, where the only thing I could tell their relatives is that they'll likely be dead in 6 to 8 months. Now, if the same person comes into that same building and let's say is a 25-year-old who's newly infected with HIV, and I start them on a triple combination like a triplet or some similar combination, you can mathematically predict that they will live an additional 50 years. So that may be one of the most important accomplishments of the translation of fundamental basic research to a therapy for a globally important disease. Now, I can't talk about treatment or AIDS without talking about the role of activism. So I want to get back. There was a reason for the Ronald Reagan slide. So remember, during the early 80s, I told you Reagan said, "I'm not going to get up," despite the fact that Elizabeth Taylor dissed him really badly for not doing that, because they were good friends. He didn't get up and talk about AIDS, but he told me and Jim Curran and Howard Jaffe and the people at the NIH that go ahead and do that. This is an important problem. So accidentally, I became the face of the federal government because I was in the newspapers, I was on television a lot. So when they thought AIDS, federal government, Fauci. So when the gay community started to realize that the government was not responding appropriately enough, they started to do something that in and of itself is historic in a very, very positive way. So here's a picture of somebody that some of you may recognize. His name is Larry Kramer. He is an award-winning playwright, screenwriter. He was nominated for an Oscar for writing the screenplay of Women in Love. He just won 3 Emmys for his play on Broadway that's still running called The Normal Heart. He decided that he wanted to get the attention of the federal government, i.e. me, even though I wasn't the federal government. So he engaged in a bunch of theatrical maneuvers that were really quite effective. He, as some of you may know, started ACT UP New York and is the co-founder of Gay Men's Health Crisis. So he has a very strong commitment to the gay community. He was it's very interesting, I have to tell you this even though, because this is part of my personal journey. He wrote a book called The Faggots in the 1970s. Now, The Faggots was a book about the sexual revolution among gay men and the bathhouse culture. And as a gay man, he warned, though he didn't know what it was, that if they continued to have completely uninhibited promiscuous sex, they're going to get an infectious disease or diseases that's going to destroy them. He said that in the 70s. He was completely vilified by the gay community who thought that he was trying to put a damper on their newly found sexual freedom. He went on to write a number of plays. This is The Normal Heart that's on Broadway. Interestingly, The Destiny of Me, I got to know him very well. I'm jumping ahead of myself. The Destiny of Me is a play in which I'm a character in the play and my wife is the nurse in the play. He called me Tony Della Vita, Tony of Life. And it was a story about a doctor who was a complete incompetent idiot, which was me. All right. So, but he actually did more than that. He wanted to get our attention. So in the San Francisco Chronicle, in June of 1988, in the magazine section, on the cover, I Called You Murderers, an open letter to an incompetent idiot, Dr. Anthony Fauci of the National Institute of Allergy and Infectious Diseases. That was his way of saying, I don't think the government is paying enough attention to HIV and AIDS. So a movement began that was a wonderful movement now in retrospect, and I'm going to tell you a minute or two about it. The FDA and the scientific community were extremely rigid in looking at a disease in which everybody had a median survival of 6 to 8 months and treating it like hypertension. We'll do a clinical trial, we'll exclude you for this, it'll take 7 years to approve the drug. They were saying, no, you can't do that. So they were very, very concerned about the slowness and the rigidity of getting into a clinical trial, which means that if you have a drug that you haven't proven works, but you want to at least have a chance because you know all your friends are dying, you want access to that. But the FDA rules, and even the scientist rules, are, I'm sorry, these are the entry criteria for the clinical trial. So many, many people were excluded. They wanted to change that. So here they are demonstrating in front of the FDA. This was prior to their becoming sophisticated. They knew that I was a scientist. They thought I worked at the FDA. So they demonstrated at the FDA with Dr. Fauci, you are killing us by not making drugs available. When they found out that I had nothing to do with the FDA and I was actually at the NIH, they said, let's storm the NIH. So they just happened to have the wrong property. They were in Rockville instead of Bethesda, but what's the difference? So here is them outside of the window of our building with smoke bombs and lying down with a die-in in front of our offices at the NIH. Then I did something, and I tell you the truth, I'm not sure exactly why I did it, I just did it. The Montgomery County Police and the NIH police and the FBI were on the campus because this was turning into a mini riot, and they were going to arrest everybody. So I came down from my office, and I spoke to the police, and I said, don't arrest anybody. Get 5 people who can be representative and bring them up to my office, and I'll talk to them about some of their concerns. Because I had been reading and listening to what they were saying, and it was making perfect sense. But because of the theater of what they were doing, they completely turned off the established scientific community, who is never amenable to being questioned about what we do, particularly when it's by somebody dressed in goth clothing with a few earrings and a mohawk haircut. It just run for the hills. So I said, come up to my office and we'll talk. And we had a conversation, which was the first time that anybody ever sat down and spoke with the activists. And I got to tell you, retrospectively, it It was one of the best things that I've ever done, because from that dialogue came a give and take among the activists in the federal government, where they are now an important component of every clinical trial that we design. On every protocol that we do, the activists are involved in the design, including on the FDA advisory committees. So you can't talk about HIV/AIDS without talking about the importance of activism. I almost lost my job, and I'll tell you the story of this. This is Marty Delaney, who is a gay activist from San Francisco, who was much more cerebral and intellectual than Larry Kramer, who was just iconoclastic. And he was fighting for what's called parallel track, which means that if you start a clinical trial and you restrict the entry because you can only have a certain number of people in a clinical trial, don't exclude people who don't have access. Have a parallel track where, with an informed consent, you won't interfere with the integrity of the trial, but you'll allow other people to have access. It was called parallel track. And he was on the phone convincing me that I should come out publicly against this. The FDA was completely against it, totally against it. Understandably, with all due respect to them, they're good people, but they were against this. He convinced me to be for it. So he invited me to San Francisco to see some of the people who were infected with HIV and to learn a little bit more about the Castro community. So we spent a half a day in the Castro. And then he put me in a town hall meeting in downtown San Francisco, right off Union Square. And I got up and he said, "Tony, would you come out, please, and be publicly for the parallel track?" Well, I did. What I didn't know is that there was a New York Times reporter in the first row. So I came out and it says, "AIDS researcher seeks wide access." And this is exactly from the New York Times article. In a major shift sought by those involved in the fight against AIDS, the chief of federal research on AIDS has called for a new system that would allow patients far greater access to experimental drugs. I call this a parallel track to clinical trials. So when I was flying back on the red eye from San Francisco and landed, I saw this in the New York Times, and I immediately got multiple calls from the Department of Health and Human Services saying that I was in serious trouble. Make a long story short, I wasn't. Getting back to be friends with anybody, the President of the United States at the time was George H.W. Bush. And I got to convince him that actually parallel track was the way to go, and he took it. So I didn't lose my job, and the FDA came out the next day saying, "What a wonderful idea this is." They actually did. It was amazing. So let's fast forward now in activism. The activists in the 80s were demonstrating to have access to drugs that were not proven to be effective yet, but they wanted a chance. In Africa, which really reached ahead in the Durban meeting of the International AIDS Society in 2000, they borrowed a page from the gay activist playbook and said, "We want drugs because we now know they work. So why don't we have access?" And there was a feeling, I think it was submerged subconscious racism or something, that didn't think you could actually go to Africa and treat people in Africa every day for a disease. Oh, they wouldn't take the medications, which, as we know now, is total nonsense. So that gets to the birth of PEPFAR. So I want to tell you about, everybody knows about PEPFAR. I'll tell you how PEPFAR came about. President George W. Bush in 2002 sent, this is Tommy Thompson, who was the secretary of HHS at the time, and me, to Africa, and asked me the question. He said, he brought me into his office in the Roosevelt room and said, "I want you to go to Africa, and I want you to figure out something that could be a game changer, something that we could do for developing nations, particularly Africa and maybe the Caribbean, which could actually turn around and give them something that we as a rich nation have an obligation to do." Now, for the people who hate George W. Bush, you wouldn't believe that he said that, but he said that. So Tommy Thompson and I went to sub-Saharan Africa, and we stopped at a bunch of countries to see if it would be feasible to do that. And in Africa, particularly in a place like Uganda, there was organizations like the AIDS Service Organization, or TASO, which Alex Coutinho was the head of at the time. So in one of my delving into the community there, I wanted to see if you can actually implement the program. So here's me, it's a dark, you can't see it, making rounds in a hospital in Kampala. And it was sort of the worst deja vu I ever had, because these guys, these African doctors, were me in 1981. They had the patients who had the disease. They had no drugs for them. The difference is drugs existed, but they didn't have them. With me, there were no drugs. We just didn't have them. So what we did is we went into the community. Here's me with a young 19-year-old woman who works at the AIDS Service Organization. And she said, with Alex Coutinho's go-ahead, take me into the bush and see that you can actually get drugs to people who are in rural areas. So here's her on a motorcycle. I took this picture from the Land Rover behind her. She took me to the villages. Here we are in a village where there must have been about 12% of the village was infected, and 3 or 4 of these children were also infected there. But she was delivering drugs. So I went back to Washington, and I worked for several months with staff members some of you may recognize. Again, I hate to repeat it, but it's true. Be nice to everybody, because when George H.W. Bush was the president, a low-level staffer that was working in the White House was a person named Josh Bolten. And Josh Bolten ultimately turned out to be the chief of staff to the president. And there isn't no less powerful person than the chief of staff to the president. So when I came back to Washington, the president asked me to work with Josh Bolten in trying to figure out a formula that could put billions of dollars to prevent, treat, and care for HIV-infected individuals. But his one mandate to me, the president's mandate, was it's got to be a game changer and it's got to be accountable. He refused to be giving money to individual countries because he thought they were just going to suck up the money and nothing good was going to happen. So I spent about 7 months from around June till around the end of December, the beginning of January, going back and forth with different versions. And the president called it the Chevrolet version, the Oldsmobile version, and the Mercedes version. And the Mercedes version was the most expensive one. So we finally put it together and was getting ready to present it, but it would cost $15 billion. So I got a real taste of Washington hardball, because OMB, the Office of Management and the Budget, which is the original description of no, that you can't do it because it's too expensive, they were dead set against me and were really, in many respects, I can say it now, not OMB in general, because the people who were there are no longer there, were really trying to undermine this effort, saying, you're going to convince the president to spend $15 billion? So I did that, and I went back and forth and back and forth. Finally, they said, we're close to it, but we need some outside verification. So they said, what we want you to do, we want you to get 4 people who are actually on the ground doing this, who will testify that your formula, this was a big mathematical model, will work. But we want you to hear in 48 hours. So how do you do that? So I said, the 4 people that I know, I got on the phone, I called up Paul Farmer, who was in Haiti at the time. I called up Eric Gooseby, the current ambassador, who was in Rwanda at the time. I called Bill Pop, who's a Haitian, and Peter McGenye, who is the Ugandan doctor. And I said, and the White House was very, very secretive. We want you to bring him here, but you can't tell them why they're coming. And I said, how do you get somebody to come 5,000, 10,000 miles? And I said, well, you got to get him. So I got on the phone. He said, trust me, come to Washington. And I can't tell you why, but it's really going to be very important. Now, all of these 4 people were pushing for universal access. So they kind of suspected why I was bringing them to Washington. So they came to Washington, and I wasn't supposed to prep them. I just was supposed to bring them to the White House so that Mitch Daniels, who was the head of OMB, would find out if this was really something crazy or was workable. So I told a white lie. I told them that I would not talk to them before, but I lied. I took them to a restaurant in Bethesda, and I want to show you this picture because this is the restaurant where Paul Farmer and I and Peter McGinty and others, when I briefed them about what was going on and what they would say, this reminded me of that restaurant in the Bronx that Michael Corleone shot Solosa the Turk and the police captain, remember in The Godfather, it was looked just like that restaurant. Nobody got shot, but they went, they convinced OMB, and the president in his State of the Union address declared the development of PEPFAR. And that's history. You know now that PEPFAR, as of just this past fall, 3.2 million people are receiving ARVs, 114,000 infants who would have been infected or not infected to mother-to-child transmission, and 11 million people are receiving care. If you add PEPFAR, the Global Fund, and philanthropies, there are currently today 6.6 million people whose lives are being saved in low and middle income countries because of the availability of drugs. I'm going to get back to that in a second because this is the challenge of the future. Because despite the fact that 6.6 million people are being treated, and the life expectancy, this is a study from Uganda, has major league increases. That's the good news. The sobering news is that only 40% of the people who could benefit from it in low and middle income countries are receiving it. And catastrophically, for every one person we put on therapy, 2 to 3 people get newly infected, which means what? Prevention, which is really the thing that we're emphasizing now. So I'm going to tell you one more story, and then we'll just go and finish and have some questions. The story is you can't talk about prevention without talking about this person. Anybody recognize this guy? You all recognize, you're all old enough. This is C. Everett Koop, who, interestingly, I love Washington because it's such a living paradox. C. Everett Koop was brought from Pennsylvania, where he was the chief of the CHOP, the Children's Hospital of Pennsylvania Surgery. He was felt to be a conservative because he fought for the lives of kids who had deformities. He did an operation. He separated the first Siamese twin operation. So they brought him to Washington because they thought, this is Ronald Reagan now, brings him to Washington because he thought that he was an arch conservative. So the liberals in Washington decided they were going to block his nomination. So paradox of all paradoxes, Teddy Kennedy and others were trying to block him. He was going through some very, very difficult stress. He came to Washington, and 7 months went by, and he had multiple hearings, and all they did was blast him because they didn't want to approve him as the Surgeon General. However, the Surgeon General, and inside the Beltway secret, lives on the campus of the NIH. So C. Everett Koop was felt that he was getting very, very nervous and tense. His blood pressure was up, so he asked for a doctor. So they said, oh, Tony Fauci's a pretty good doctor. He'll take care of you. So I became C. Everett Koop's personal physician. And I went over him, and people were putting him on a lot. I told him I was going to tell you this story, so I'm not divulging anything I shouldn't. So he was on all these medications, and what he really had was, he was just totally wiped out and stressed. So I made, after about a month of worked him up, I worked him up from stem to stern, and I made the diagnosis of him, and it's a very common diagnosis. It's the Welcome to Washington Traumatic Stress Disorder. So I got him off all his medications, and we became very good friends. So this is my desk at the NIH, and this is his house. You could see it right out my window. So every evening, or not every evening, that's hyperbole, maybe twice a week, he would, on his way home, stop in my office. I used to work till 9 o'clock at night, and so I was there, and he said, tell me about this AIDS thing. Remember, he's a surgeon who knows nothing about AIDS. He became fascinated with AIDS. He became a scholar on AIDS. Here's a picture of he and I in his office. This was years later, right before he was getting ready to retire, till the point where he knew so much about it that he said he wanted to write a public Surgeon General's report on AIDS, as well as a letter to every household on AIDS. And he did that. The only trouble is the conservatives in Washington got really upset that this would go out. So they didn't give him any money to publish it. So for those of you who've been, any of you have been to the NIH, there's a thing called an interagency agreement, which means I have the legal authority to sign over a limited amount of money to another agency. So I gave him $250,000 from my budget to put out the Surgeon General's report. He did, much to the dismay of a lot of people, because he said in the report things like gay men, anal sex, oral sex, injection drug use, to the point that I'm going to show you a very representative cartoon that appeared right after the Surgeon General's report came out. There's a woman going to work and says, if anything comes in the mail from the Surgeon General, don't open it. So that was the story of prevention. So what about prevention? There are a number of prevention modalities that absolutely work. The real issue is to implement them, and they're listed here. Everything from clean syringes, use of condoms, pre-exposure prophylaxis, mother-to-child transmission. We now have within our armamentarium what it takes to turn around the HIV pandemic. This is the efficacy of circumcision in an African study. Almost 70% effective between uncircumcised and circumcised. If we had a vaccine that was 68% effective, it would get approved like that. And yet we don't have the money to fully implement circumcision programs in Africa. We know that topical microbicides work. We know that if you take a gel and embed it with tenofovir, depending on the adherence, you can significantly block the spread of HIV to heterosexual women. We know that pre-exposure prophylaxis works in a study in men who have sex with men. I just want to take 30 seconds to tell you of the importance of adherence to a modality that works. So the overall reduction was 44% in all men. And this is uninfected men who have sex with men. You give them a pill of tenofovir once a day or Truvada. 44% efficacy. If you ask them if they take their medication and they say, yeah, I take it or not, and you only count the people who admitted that they took their medication, the efficacy was 72%. If you said, I still don't believe you, and you draw their blood and you compare those who have a blood level with those who have not a blood level, the efficacy is 91%, which tells you that you can have an effective therapy, but if they don't take it or an effective prophylaxis, it's not going to work. That's key in how we're going to approach the AIDS pandemic. There were 2 randomized trials that was presented in Rome that pre-exposure prophylaxis works among heterosexuals. We thought it would only be in gay men. No, it works in whether you're the uninfected sexual partner, a woman or a man, it works. What about treatment as prevention? This is probably the most important thing that has occurred in AIDS clinical trials in the last decade. There has always been a tension between resources for prevention and resources for treatment. Now we know, these studies suggested it in cohort studies, decreased community viral load in San Francisco, heterosexual cohorts in Vancouver, injection drug users. If you treat people, the rate of infection goes down in the community. A study was recently published that showed that if you look at discordant couples in which one person is infected and the other one is not, and you treat the infected person and bring their viral load down to essentially below detectable level, there's a 96% decrease in the risk of transmitting infection to the uninfected partner. This is it, folks. The more people you treat, the more infections you're going to prevent. And that's really going to be the driving force now of being very aggressive. In this regard, there is a study that is looking at the feasibility of what we call testing, voluntary testing, linking to care and treating in a study that's a 3-year study that started in October, which is a study that has 6 cities, but 2 of which are the key cities, is the South Bronx and The leader of that study is sitting right there, Wafa El-Sada, who does it in the South Bronx and the people in Washington, D.C., to see if, in fact, it's going to be feasible to get to the community, to get them voluntarily tested. I'm going to close on a vaccine. We've been searching for a vaccine for about 24 years. The first positive result came from a trial in Thailand. It certainly is not ready for prime time. It was only 31% effective, but it proved the concept that we can have a vaccine. Right now, we're getting much more sophisticated about it by structure-based vaccine design. I want to spend literally 30 seconds on this because this, if I gave you the details of this, this can be very heavy and dense. What we've found out is that certain rare individuals make broadly reacting neutralizing antibodies to important epitopes. This is the envelope spike, particularly the CD4 combining site. The trouble is we don't make it readily, easily, and we make it too late. So the challenge for vaccinology is how do you get these epitopes and make an epitope into an immunogen so that when you vaccinate somebody, they actually do make broadly reacting neutralizing antibodies. So the future is going to be, and this is very unusual, it breaks the paradigm of normal infectious diseases. And that is that there's going to be no unidimensional way to prevent HIV. It's going to be different for different populations. So what we're thinking about now, in the absence of a vaccine, is a combination of HIV prevention modalities. When we get a vaccine, which I hope we will, it will be one of the combinations. Importantly, is this treatment as prevention. So every time you treat an HIV-infected individual, you remove from the cohort a potential spreader of infection. So the days of the tension between treatment and prevention should be put behind us. So this is a picture of me last week at the Rome meeting where I was addressing the assembly there of about 6,000 people were there. And I just want to close by leaving you with the message that I left them after 30 years of reflecting about where we are. We have enormous scientific advances. It is time now, and I know we have constrained resources, but just like the activists put the pressure on us in the 1980s, you know, as a responsible community, we need to put the pressure on to implement the scientific advances. Namely, we know what we need to do to get our arms around this pandemic, and we're not going to wait for a vaccine. Science magazine was kind enough to allow me to summarize in 600 words my prediction for what we need to do. And I published an article a few weeks ago in Science, an editorial, that I just want to close this discussion with what I said in that article. It's entitled, Let Science Inform Policy, and it's just what I said. We now have an unprecedented opportunity based on scientific data to control and ultimately end the AIDS pandemic. Major investments in implementation now will save even greater expenditures in the future, and in the meantime, countless lives can be saved. Thank you.
Thank you very much. The floor is now open for questions. I'm sure there will be many, and there's a microphone in the center of the room.
Thank you for your presentation. I'd like to go back into the question of education up there that you had. I know many people who, both straight and gay, have died in the past 40 years of AIDS. And I remember how ignorant I was in the beginning of this pandemic as to what caused it. Our society, when you compare it to Europe in terms of sex education down to the elementary school, is basically backwards. I was in the Netherlands in 2004, 2005, several times, examining educational systems like that. What do you make of that kind of aspect of it? The fact that kids in our society, we have uneven levels of sex education at the most basic level that creates lack of awareness about these issues that can create infection that we see happening today.
Well, I think you make an excellent point. A denial that individuals are having sex at a certain age has been proven to be completely off the mark by the amounts of unwanted teen pregnancies. I mean, that's just proof positive of that. When you want to start educating young people about sex, you have to educate them before they start having sex. And I think the denial in a somewhat puritanical society of when people start having sex usually makes us about 3 or 4 years too late in the process. So if you're suggesting that we should have and should now intensify sexual education, sex education among youth, the answer is absolutely. That isn't the only thing that's going to get us out of this, because a lot of what goes on now, particularly in this country, has to do with lack of access to people who are most at risk. It has to do with, indirectly with sex education. But you've got to remember that early on in the beginning, and this is sad, because of the awareness of stigma and the sensitivity of being politically correct and not singling out a group, we said, and I can go back and even find some advertisements that say that AIDS is an equal opportunity employer. That's bull. AIDS is not an equal opportunity employer. If you're a co-ed in Iowa and having sex with the guy down the hall, the chances of your getting infected are infinitely less than if you're a 16-year-old African-American girl in the Bronx having sex with her boyfriend. And that's just the way it is. So if you want prevention, you got to target populations, and you got to have the people who are credible to the population out there. You don't need me, a white guy in a suit, going to the Bronx educating people about how to avoid infection. You need the community to get involved with that. Anyway, sorry for preaching, but that's the way I feel. Yeah.
Thanks a lot for that. This is actually a follow-up on that, on the last question, and it's really about the sort of neglected stepchild of behavior change programs, which you didn't talk about that much. For example, you talked about the treatment as prevention trial. It's actually, in the African sites, as I understand it, of that trial, about half the infections were actually, that occurred in those sites were actually due to concurrent partnerships in those, in the population. And obviously, treatment as prevention won't do much to affect that.
No,
that's actually
can I interrupt you just for a second?
Yeah.
Treatment as prevention is when you treat an infected person.
That's right.
Okay.
That was from that Cohen and Al
Right, so
trial.
I don't understand what you mean that it doesn't work. Any treated person, regardless of who that person is, if you treat them, you're going to decrease their chance.
For sure, but you'd have to blanket the entire HIV-positive population, including those who are
Of course,
in acute
no,
infection. Yeah.
no, you're absolutely
Yes,
right. If you
yeah.
wanted in and of itself
Yeah.
to decrease the epidemic, we don't have the resources to blanket the entire population.
Right.
So that's not going to work alone.
Sure.
I'm just saying that as a scientific fact, when you treat an infected person, you make that person extremely unlikely to infect someone else. So whether we have the resources to penetrate entire populations is an entirely different question.
Yeah.
I was just addressing the scientific credibility of that approach.
Great.
Okay.
But I actually have a question. I wonder,
Okay.
which is really, I didn't mean to get sidetracked on that. Of course it works. You reduce viral load, you reduce transmission. We know that. We've known that since about mother-to-child transmission, which works the same way, of course. No question about that. But we do know that there are now 9 studies using genetic linkage and other techniques that show that multiple concurrent partnerships, in other words, most infections or a significant fraction of infections in Africa are actually happening in clearly defined couples, that we actually have but that multiple concurrent partnerships in particular are responsible for a large amount of the spread, and yet there are very few interventions which actually address this particular behavior.
Right.
When you talk about targeting, this is extremely important. And there have been no, with one exception, there have been no randomized trials of interventions that address this behavior, except for one, which is as yet unpublished and actually reduced rates of genital warts in this country in a small trial by about 50%. And I just wondered, you know, it would be great if there were some scientific attention to this, because we do know that behavior change works historically. It's saved millions of lives in this country in the 1980s, for example, and in Africa and in Thailand and elsewhere in the past. And it needs more scientific attention, and I hope that NIH will.
Yeah, well, yes, NIH is. The National Institute of Mental Health are doing studies to try and understand the dynamics of concurrent sexual partners and how to interrupt it. That is a really tough nut to crack, because you're dealing with societies in which that's embedded in the culture of the society.
But they need to know those risks.
Sure,
That's
of course they
precisely
do. Of course,
the point,
of course.
so,
I mean,
anyway.
no one would deny that. Right.
Hi, that was a great talk, and it's wonderful to see the whole kind of perspective of everything. You've kind of laid out a playbook for AIDS of what we need to do to contain it, and it's got this history that going back 30 years of this perspective. What is the plan? So what my question is, it makes sense for new emerging diseases that might be coming, like a SARS or other pandemics. Does NIAID now have kind of an accepted playbook of what's going to be, so we don't have to make all the mistakes that we've done in the past and in the absence of not understanding a disease or something that's newly emerging?
Yeah. The playbook is really a science. If you look at the science that has evolved over the last 20 years, particularly the last 10 years, when you think of emerging diseases, there's different types, obviously, as you're well aware. I mean, a respiratory infection that spreads through no aspect of conduct or behavior, it just spreads, is a different story than something like HIV/AIDS. But one of the things that we have been stressing now is something that isn't NIH, it's mostly CDC and to a lesser extent WHO, is surveillance technologies that actually can detect trends in disease that may not necessarily be noticed by finally somebody reporting a new disease. If there was a way, and there are ways, you know, obviously informatics ways to do that. The other is the extraordinary power of identification of microbes by essentially getting around the standard way of having to grow a microbe in a particular culture. So that if there is somebody who's sick with something that is unidentified, we have the capability by very high throughput deep sequencing to be able to put together a good semblance of what that microbe is that we never ever had before. So rather than isolating, growing, developing a vaccine, you could sidestep that very, very easily. So when you say playbook, you know, the playbook gets rewritten. And the thing we've learned about emerging diseases, be it the flu or the scare of anthrax, is to be completely transparent and say what you don't know when you don't know it, and don't let the public, you know, start guessing about things, because particularly when you have an acute thing. I mean, AIDS is very different because AIDS was insidious. AIDS had already, at the time that those 5 patients were identified, there were hundreds of thousands of people already infected. An acute respiratory emerging infection is a bit different. You handle it a bit different. Right.
Hi, thanks so much for speaking with us today. I just had a question. You said in your concluding remarks about how, the activist organizations had been pressuring for the change in the 80s in terms of how AIDS is being addressed, and that you guys now needed to put the pressure on again in order to look at the science that exists and then apply it. So I was wondering if you're then implying that activist organizations today are not doing as much as they have in the past, and so why you think that change has been, and what the role of activist organizations has been in defining risk for HIV and AIDS.
Well, certainly, it depends on, activism has taken on different flavors. I mean, the activists of the 80s are now very sophisticated activists in a different way. So there is a big activist movement to get resources to implement, particularly in the developing world, what we know will work. That's the great frustration that I try to convey on the last two slides. Anybody can be an activist. I try to be an activist within the confines of maintaining credibility. Larry Kramer used to tell me, Tony, what you really need to do is to chain yourself to the White House gate. Well, if I chain myself to the White House gate, that's the last time I'll ever get near the White House. And the fact that I get into the White House a lot, I do a hell of a lot more good than being a 15-minute hero of chaining myself. So there are activists who are within the system. There are activists at WHO, and there are also the typical street activists who are really putting a lot of pressure. What the pressure I'd like to see is, we're in a very difficult time of fiscal constraints. I mean, you just stay awake for a couple of weeks and look at what's been going on in our own country. The other countries aren't any better. But we have to put the pressure that despite fiscal constraints, we can't forget about this problem. We have 6 million people on therapy. 9 million additional people should be on therapy given the state of their disease. And that's the reason why I stress the treatment as prevention. We don't have the resources or even the logistics to get to everybody that's infected. But we know that every time you treat somebody, that person is not going to infect anybody else. Another thing you could do is, every mother who comes into a clinic in a developing nation should be treated for HIV if they're infected. Not just given a dose of nevirapine and then say goodbye, and then a dose to the baby, but every mother should be fully treated for the rest of her life. Now, I feel very strongly about that. We don't have the resources to implement about that, but the more people like myself and others say that, and say that we almost have a moral obligation to do that, sooner or later, people will listen. My experience in Washington is I have never gotten something that I was pushing for the first time I asked. It just doesn't happen. You got to be a real pain in the neck and come back over and over again.
Thank you.
You've clearly shown that treatment as prevention works, and I'm wondering if you can speak to the history of that. We now know that that works, but we didn't know that in 2001, we didn't know that in 2002, 2003. We did know that MTCT worked, but we didn't know that treatment as prevention worked. And I'm wondering, in light of the fact that in 2003 we knew that for every one person who was putting on treatment, 3, 4, 5 people were becoming infected, why was there such a big push for PEPFAR in 2003 to be near exclusively on treatment and very little on prevention?
Well, there was really a cry to take it. Put it this way: when you have a lot of dying people coming into a clinic, it's really tough to say, we're not going to treat you. It's very difficult to do that. When I put the first model together, it was 55% treatment, 20 some odd percent prevention, and 30 some odd percent care. Now it's much, much more even balance between treatment and prevention. Just as a point of fact, it's very interesting how it evolved that treatment is prevention. It evolved even before we treated anybody, because if you look at discordant couples in a study we did in the Rakai district of Uganda, there was a direct, highly significant correlation between the level of viral load and the probability of transmitting to your sexual partner, even without treatment. Then mother-to-child transmission came, and it became very clear that the low viral load in the mother was linearly associated with non-transmissibility. Then they did the cohort studies in Canada and in Africa and San Francisco, so that the principle of low viral load is going to result in decreased risk of transmissibility was obvious. But what we needed was the randomized controlled trial to prove it. I mean, you hate to be cocky about it, but I knew what the results of 052 was going to be before we even did it. What I didn't know is would people adhere to the treatment, and they did, and they did.
Was there any political pressure to take money away from prevention, though, in those early years, 2003? Because that's the primary critique about PEPFAR, is that there's very little money for prevention because you don't want to work with people, marginalized populations, intravenous drug users.
There really wasn't any political pressure to take money away from one and do the other. It was the best judgment of the countries. We really relied on the people on the ground in the countries, what they felt was their greatest need. We weren't so ugly American presumptuous about it to say, okay, Zimbabwe, you do this, and okay, Swaziland, you do that. We went in and said, what do you think the health people, the health ministers there, would be the best for the epidemic in your country?
Then why is there why are you working through parallel? Why did PEPFAR work through parallel tracks then and not work through the Ministry of Health a lot of the time, or a lot of the implementation?
Well, we worked on what's called a bilateral agreement. Sometimes it was the Ministry of Health, the thing we wanted to stay away from. I mean, I designed it, but it was run at first by, what's his name, Randy? Forgot his name. Randy Tobias was the first one, and they asked me to get a deputy for them, and I gave him a guy who was a fellow in my lab named Mark Dybel. And Mark took over and became the head of PEPFAR, and he did a spectacular job of that. And now Eric Gooseby is also doing a great job of that. But when you say parallel, what do you mean?
I mean, a lot of the times, a lot of these, the implementation of the treatment isn't necessarily run through.
Oh, you know, the reason is that the president was very, very clear. He didn't want to be giving money to unaccountable sources. He just didn't want to do that. And he was right, because, you know, quite frankly, the Global Fund is having a lot of problem right now with, you know, Inspector General investigations about where the money's going. So this way, you just go directly to an NGO, be it Médecins Sans Frontières or something like that. That's who they give the money to, who are quite reliable.
Thank you.
Yeah.
So I'm curious, given your experience with the administrative and political side, as well as the allocation of funds in HIV research, if you think there are any generalized lessons for biomedical research about what's worked really well in choosing what research programs to pursue and how to allocate funds, compared with other areas where it seems like there's been a lot more tension at the NIH, like clinical oncology. And how is there a certain specificity to the kind of research and the kind of development that goes on in the world of HIV research where you're dealing with virology that makes the lessons very different from something that might be more applicable universally, or at least to, say, oncology?
You know, it's a great question, and I don't know the complete answer to it, even though I've lived through it, but I can tell you that the factors that went into all of those resources being given to HIV/AIDS were multifaceted. One, it was new, scary, and out of control. Even though cancer is a very important disease, and heart disease is, there's a certain complacency when you talk about a disease that you can predict what the morbidity and mortality is going to be. You know that 700,000 people a year in this country die of heart disease and 400,000 die of cancer. You know that. It happens every year, up and down. The thing with HIV is, one, it was completely unclear where it was going, but two, the activist community played a major, major role in getting that amount of resources. So lessons learned for others, I think the biggest lesson, and I don't mean to be simplistic about it, the lesson is when you put a lot of money into a problem, you really do get results. So, I mean, AIDS is the poster child of investment. You know that there are more effective antiviral drugs for HIV than the sum total of all antiviral drugs for every other virus combined total. That's not an accident. So that means that if the drug companies and the public demand really wanted it, you could probably get anything you want scientifically, really. I make the same argument about, you know, malaria and tuberculosis. I mean, look at the disease burden of malaria and tuberculosis. Only now that we are global in our thinking, and we don't only think provincially about what's in the United States. You go to Africa for reasons mostly of HIV/AIDS, and you find out when you talk to the people there, they say, oh, by the way, you know, 800,000 kids are dying of malaria each year, and 1.7, 1.9 million people are dying of tuberculosis. So that's sort of jolting in that.
Thank you.
You're welcome.
Hi. Okay. I'd also really like to thank you for your talk. It was really great. So I had a question about, I know you mentioned at the beginning of your talk that people kind of accused you of being an alarmist at the beginning of the whole AIDS epidemic. And I was just wondering, like, with all of the possible epidemics or pandemics that we're facing today, with like bird flu is one of the examples of that. I know now they're coming out with like a movie about the bird flu that's like
I just saw it today. I saw a pre-screening today, actually.
Like things like that, and like the local news kind of blows everything up, all of these kinds of things. So I was wondering what's your stance on these kind of what a lot of people see as alarmist kind of takes on all of these diseases, and do you think it's really alarmism? Is it really just like kind of unnecessary, or is it more education, and or is it even creating a lot of the stigmas on these diseases that we have?
Yeah, it varies. It's a good question, but it varies from disease to disease. I mean, when you're talking about really dramatic thing like an outbreak of a highly contagious, highly lethal flu, that's different. You don't need alarm. What you need is a measured approach, because when you see the movie, which I recommend, it's really a great movie, particularly if you like Matt Damon. And who else was in that movie? Marion Cotillard. She's not bad either. Gwyneth Paltrow. Is that there are certain things about alarmism that you've really got to be careful of. We sort of saw that in the anthrax attack of people who were going out and stocking up on ciprofloxacin and getting it stocked out from the drugstores, or even during the H5N1, when people were going out and buying Tamiflu, and the concern about taking Tamiflu for anything and everything that happens to you. So there's a balance of alarmism that's inappropriate, and the way that we try to do that, as I mentioned in answer to another question, is to be very transparent as public health officials, and to not be afraid of saying you don't know the answer. Things get really messed up when a reporter sticks a microphone in front of you and asks you a question.
Speaking of the microphone.
Okay, we're good. And you don't know the answer, and you think it's better to guess than to say you don't know. That's a huge mistake. And people have done that. They've done that with the anthrax attack. There was some guessing on the part of public health officials. It was done with H5N1 when it was first very scary. So that's the lesson that we try to teach ourselves. We do these postmortems in the government about what was good or what was bad about the response, and it's pretty clear that you got to be as transparent as possible. One of the things that's difficult in our day and age is the blogosphere, because any idiot can say whatever they want and it goes viral on you, and then it's kind of tough to play catch up of getting the truth out. That's a hint about this movie that you're going to see.
Thanks.
You're welcome.
Hi. My interest is in the science of HIV/AIDS, and you've always been a bit of a scientist, I think, as well as a doctor. In fact, you seem almost more of a scientist than a doctor. But you've presented the material today as if there really are no more questions or puzzles in HIV science.
Oh.
And I think you'd probably say that that's not quite true.
That's for sure.
So what I'm wondering is there any kind of system in NIAID for people to make suggestions about where you might have things wrong? A sort of red team. You know how in security now they have these red teams of script writers who suggest possible dangers, and they deal with possible threats in that way, things they might not otherwise think of. Is there a red team at the NIAID, or are you somehow a king to whom the courtiers don't dare mention anything which might disagree with what you think?
I'm treated with a phenomenal degree of disrespect in my institute. Don't worry about that. No, we're a free and open society there. No, we do an awful lot of outreach to the scientific community. The granting process itself is a built-in system for good ideas. The R01 process of people putting interesting ideas in and getting peer-reviewed. But in addition to that, we continually have workshops of trying to figure out what the best approach is. It is clearly an ideas-driven process as opposed to a king dictating what gets done. That, in fact, is antithetical to what science is.
Well, may I just ask
And by the way, I am a pretty good doctor, too.
Good. May I just ask you, what are the things which we're still puzzled about and which you haven't solved yet? What kind of things are we still wrestling with to see how they work? Or
Okay, let me tell you what the real thing that gives me headaches that we don't know. The body does not make an adequate immune response against HIV. This is unprecedented in the history of any microbe. So if you look at vaccines that we've made that were successful, this is critical because this is so unique that people don't appreciate how unique it is. So take smallpox, polio, measles, 3 big killers and maimers. Smallpox, measles doesn't kill a lot, but in some developing countries it kills a certain percent. The interesting news is that a vast majority of people make an adequate immune response to clear the virus. So when we develop a vaccine, we've already have a proof of concept that the body is capable of making an adequate immune response that not only will clear the virus, but will leave you with lifelong protection. Astoundingly, that is not the case with HIV. The body does not make an adequate immune response. There is not one single case that has been documented among the 60 million people who've been infected where somebody gets infected, gets established disease, and completely eliminates the virus from their body. So we have a real problem. The big tenet of vaccinologists, which Steve will tell you, is mimic natural infection and you'll get a great vaccine. The one thing you don't want to do with HIV is mimic natural infection with a vaccine, because natural infection doesn't work. So we have an enormous challenge of how to get the body, induce the body to make a response that's even more powerful than the natural response. That's the one scientific issue that I think is the holy grail of HIV science.
Thank you.
So I just have a quick question. Thank you very much. So throughout your presentation, you've discussed the necessity of continuing implementation of treatment and prevention measures against HIV. And also, you mentioned briefly the restrictions on resources that you're working with today. So I was wondering if you could shed some light on where you think the funds to treat those 6 million people who are already on ARVs and the 9 million people out there who you already haven't found and treated. Where do you think those funds are going to come from, and how are you going to distribute them? And do you see any new fields? You just talked about a new scientific question, or the big unanswered scientific question in the field. Do you see, or do you think that you'll divert resources into answering that question, or do you want to continue to focus money, expenditures on the treatment and prevention that we already have so far, those measures?
Well, that's a good question. My responsibility as the director of a research program is to develop drugs and develop vaccines and develop diagnostics. I get involved in the policy because of the nature of my position about people in high places come to me and say, what is it that you think we should be doing? And we do it as a team. It isn't like one person dictates it. It's a team. So you say, where are those resources going to come from? That's a really good question. I don't know, because particularly now, it's a really, really bad time with the fiscal constraints. But I got some ideas. If you look at the amount of money that's pledged to the Global Fund by other nations and how much they actually put into it, they don't give anything. There are major European countries who don't put a penny into the Global Fund. China is spending billions of dollars in building up things in Africa in order to have, I think, an economic impact and inroads in Africa. They haven't put a penny into treatment of Africans. Now I know I'm going to get in trouble. Somebody's going to email the Chinese embassy and I'm going to be spending my next day answering emails. Just kidding. I don't really care. But that's the job. I mean, those are the things that we need to do.
Please join me in thanking Professor Fauci for his remarkable talk.